name is Amanda Falk. I am a partner and chief clinical officer at The Dorm, which is a treatment community for young adults ages 18 to 30. Right now, this is our last presentation of the year, and we're just in the middle of holiday season, which we know can certainly be a stressful time for people in general. Certainly for our young adult clients, it can be quite stressful, sometimes due to the fact that they're spending more time with their family members and sort of old patterns of behavior can re-emerge. So while family therapy and parent coaching and the family work is always important in a treatment process, it's particularly important during this time of year. And this is why we're really excited for today's presentation and to have Ben Brafman here of the Sylvia Brafman Mental Health Center to speak about unpacking effective family therapy. Ben Brafman has over 25 years of experience in behavioral health. He is a co-founder and clinical director of the Sylvia Brafman Mental Health Center. He has developed several clinical programs and has been instrumental in teaching other professionals about how to effectively manage clinical programs and clinical programming. He is recognized as a leading authority in behavioral health and is a pioneer in clinical services. And we're so excited to have you here today to be presenting on this important topic. So without further ado, I'm going to turn this presentation over to Ben Brafman.
Hey, thank you, Amanda. Appreciate it. And I appreciate everybody being on this Zoom this afternoon and taking some time. Ben Brafman, there's going to be some slides, so I'll get into that in a second. But to even the playing field, I'm not going to go around the room and ask you who you are and what you do. That would take way too long. It's good enough that you're all you got your eyeballs on me. I did want to tell you who I am. I'm a licensed mental health counselor. Been licensed since I believe 1998. I'm a master certified addiction professional, board certified supervisor in the state of Florida and about 15 other states in the country. And as Amanda said, I've been in behavioral health roughly since the mid 90s. Today, I'm going to be presenting on some case studies and related back to family systems and substance abuse and things that I'm pretty sure all of you are familiar with. As I go through the presentation, one of the things that I shared with Amanda that I want to share with all of you is that I am not a magician. I don't manipulate. I don't throw out kind of these the sizzle and not have the steak. I like to ask a lot of questions. So in my presentation, you'll see threaded through the whole thing is our questions. And you'll know because I'll ask the questions. I'll say this is what spurned this question at this time. And there are different types of therapeutic questions to ask at different times, which we will get into. And then Amanda, one other thing I wanted to mention, which originally was not part of the presentation, but you mentioned something about the holidays. So I wanted to mention something about the holidays related to family therapy. If many of you look at your calendar, you'll see that there's major holidays throughout the year. We have, we just finished Thanksgiving. We have Christmas coming up. And a lot of times our calendars give us the opportunity to create what I like to call an open window or an open door for a family to heal again in any part of the family, whether it's mom and dad, husband, wife, the children, for them to be, to kind of reset and redo. Of course, we have, the new year right around the corner, and all of us are going to make our New Year's resolutions, which will last about 24 hours. But in family therapy, It's an opportunity to, like, press the button. Okay, that was then, this is now. And it's built in, and it's recognized culturally, here in our, in our Western culture, that yeah, that's what people do. And you can even get into some of the rituals that families have that are very effective within, within family therapy. So I wanted to mention that, Amanda, because you had brought that up, and I thought it was a good point. That's just another tool that, that all these professionals can use, as they go about their business. Can we get to the slide? Okay, so this is the Sylvia Brafman Mental Health Center. Let's go to the introduction. So, like I said, my name is Ben Brafman. I am the Chief Clinical Officer of the Sylvia Brafman Mental Health Center. I've been working in behavioral health over 25 years. I suppose my specialty is in family therapy. I've been working with families for almost that whole time. I grew up in behavioral health. I started off as a as what was known as a mental health tech, and moved up to case management and discharge planning, and then, as I was getting my master's degree, I was working in any kind of setting possible, psychiatric, inpatient, outpatient, whatever I can get my hands on. But I wanted to immerse myself in behavioral health, so I had as much experience as possible. I have worked in the nonprofit sector. I've worked in the for-profit sector, and even though their agendas are different on paper, a lot of it is the same. I learned about politics of behavioral health. I learned about insurance a great deal, as I grew up in this industry, and so I felt, in roughly around 2006, after I'd been in the field for about over 10 years, I felt it was time for me to open up my own treatment center, which I did in 2007, which was Destination Hope. It was an all-male gender facility, 12 beds. And I added women about 3 years later, and we added a mental health component and really built it up to about 150 bed facility from detox to to complete outpatient. During that whole time period, I got licensed, I got my master's, I got my certification as addiction professional. And one of the things I wanted to share with everybody is I developed my clinical philosophy, which you'll hear about today in the case studies, and that is, in the 90s, dual diagnosis was all the rage. The drug addicts went to the left and the schizophrenics went to the right, and everybody debated over what came first, your mental illness or your addiction. And honestly, even back then, before I even knew anything, I didn't really care. I just wanted to treat the person, and that really stayed with me really throughout my career up until now. At the Sylvia Brafman Mental Health Center, our philosophy is that everything is under the umbrella of behavioral health. We're primary mental illness, and even in treating the disease of addiction, we treat it like a mental illness. As many of you know, addiction has its roots in trauma, and also in obsessive compulsive disorder. And so we treat it as such, and we've had some really good success. But I wanted to mention that only because as I go through, you may hear me say things along those lines and relate to it. So I wanted you to know, where I stand with all of that. Just fast forward, I've I had my own pharmacy at one point, I had a wellness center, all that stuff. we'll just move forward to Sylvia Brafman. We can go to the next. We can go to the next slide. So I know, Jamie, you're still on, right?
I'm on.
Hey, everybody, this Jamie's our CEO at Sylvia Brafman. Jamie and I have known each other for, I guess, around 15 years now. I'm going to share some personal stuff. I don't think he'll mind, but Jamie was a patient at Destination Hope, and I actually kicked him out of treatment. He was there for a very long time. He's got a whole story to tell, but he was on treatment center number 4, I believe, of 7, and he really he really was making a mess of himself. He was kicked out. Thank God that later on he did get it together. A couple of years ago, I sold Destination Hope, and I really wanted to go down this mental health well, and I really do primary mental health. There's a substance abuse treatment center in every corner. I feel like we're in South Florida, so there's a substance abuse program in every corner. I wanted to do something different, and again, that leads back to the philosophy that I shared with you guys. And I reached out to Jamie, and I didn't want to be a CEO anymore. Frankly, I wanted Jamie to be the CEO, and he loves the business side of it. I love the clinical side of it. I feel like he and I are right where we should be, and it's been 2.5 years now that Sylvia Brafman is open, and we're doing well. So it's a sort of a shout out to Jamie, but also we are close, and one of the things that he says that really means a lot to me is the family component of his treatment experience. I stayed in touch with his mom even after his treatment, and I did that because I know how important families are, and to the success of families and of the individual, and stayed in touch with his mom, still stay in touch with her. And so that was really important to her, really important to him, and just spoke to the credibility of the philosophy that I carry. So Jamie and I are running the Sylvia Brafman Mental Health Center. Oh, which, by the way, is named after my mother, just in case anybody was ever wondering. Go to the next slide. It's fine. All right, so I put this slide in there. This is something that you guys can take back to your practices and your treatment programs. This is a framework for why you're important. And the case studies that I'm going to talk about, one is a little bit longer than the other, but each one of them has a story to tell. One of the questions that comes up a lot is, why am I afraid to tell you who I really am? And the reasons for that are many. The reasons for that are many. You don't feel like you count. You don't feel like people will listen. You were abused. You were traumatized. You didn't have a voice. None of that. And treatment is supposed to be an opportunity and a platform for you to tell your story, to have a different perspective on who you are. Many of the patients that we get, and much of mental illness is defined by mental illness. Part of the problem that comes up in people telling their story and their truth is that they're defined by their schizophrenia, by their depression, by their anxiety, by their addiction, and they get lost in all of that. And it's important for us as change agents to allow patients to have a voice, allow patients to name their illness, to name their disease, to really put color into it and put it in its place, where it belongs. It is not who they are. It's part of who they are. So the question of why am I afraid to tell you who I am? very important question. Another question that comes up from this framework is, how do I define myself? And again, as I said, many people define themselves as I am mentally ill or I am a drug addict. And honestly, that's too myopic. That's too small. And it doesn't really tell the story. And then the next question to ask is, what is your role in your family? And you'd be surprised by the hesitation that you get, or the stumbling that you get when you ask this kind of question. Most people don't know their role in their family. They think they're one thing, but they're really another thing. I give you guys an example. So one of the things that I say when a patient comes into treatment is, I say to them, you're the representation, you're the representative of your family. You're not the problem in your family. And I usually get this crooked look, and what are you talking about? And I've been told I'm the black sheep, and I'm this and I'm that. And the truth is that within a family setting, if you hone in on this person is the problem, and if only this person would do what I need them to do, then everything would be fine. And if you look at it systemically, that's impossible. That it's a family illness. That there's a whole bunch of factors that go into a person ending up in treatment, and that it's not just about the individual. Family members, and I'll be honest with you, I'm not really sure how to define family these days. There used to be a very clean way to do it. You had your so for example, you had your hierarchy, right? You had husband and wife, and then if they had kids, they became father and mother, and then there was the subsystem of the children. But family has taken on a whole nother level, even to the point where, can you have family that's not blood? Can you define it that way? I believe that you can. I believe that we have to redefine some of the concepts that we have about what family truly is, based on all the framework that I'm talking about, based on culture, based on the episodes within the family, based on genetics, based on the history of the family, all of that stuff. So that's the framework from where I'm coming from, which leads me to the case studies. You can go to the next slide. Okay, so I'm going to share this case study with all of you. Hang on one second. Let me just see if I can. Okay, good. I can move that. I'm going to share this with all of you, and then I'm going to pose some questions, and I'll make some comments on all of this. Patient is separated from his mother at a young age, 9 years old. He is fostered by an older gentleman who dies just a couple years into parenting him. The boy is raised by his uncle, a family friend who is more like a brother to him than a father figure. The boy learns how to be resourceful, especially with his hands, building things and making computers. Very talented, but no direction, and he suffers from depression and anxiety because of the traumatization of being separated from his mother. His uncle does the best he can, but the boy is hard-headed and disdains authority. He is easily manipulated by others and influenced to do things for others' benefit. So I'm going to pause there for a second. I just want to share with you some of my inner workings. So at this point in this case study, what I've done on a piece of paper, and I'm purposely not showing you my handwriting, but basically there would be a circle with the identified patient in the middle, or the boy here, and then I would start to do these almost like put satellites around the person, like moons that are around a planet. And each moon would represent some of the things we already know in this story. So we know that he was separated from his mom. We know that he was raised by this older guy. We know that this uncle brother was involved. We know that he's got some skills with his hands. We know that he disdains authority. And then we've got anxiety and depression we're dealing with. And then you have your own insights going into this case study, right? You're starting to think. I've shared with you a lot of information in a paragraph. You all have your own sense and your own intuition about what's happening here. So you should start to take notes and create this framework. And again, what is this person trying to tell us? Why am I afraid to tell you who I am? How do they define themselves? And what is their role in their family, right? Those are the questions that I posed before. He soon gets into drugs and alcohol and anything else that gives him the sense of power and control. Despite all this, he falls in love with a woman from a wealthy family, but he still feels empty inside. He begins to emotionally abuse the ones he loves around him while excelling in his education and career. His uncle remains a role model, but DV is jealous of him and has an eternal rivalry, creating chaos where none should exist. He gets married and his wife becomes pregnant. In a fit of rage over something he only made up in his head, he chokes her and she passes out. She dies shortly after, but does give birth to twins. The uncle keeps the twins from DV, hiding them with other family because he feels DV will hurt them somehow. DV becomes more obsessed and paranoid that he can't locate his children. He and uncle have a huge falling out, and DV isolates himself with people that can supply him with drugs, say yes, and continue to manipulate him. So again, we're getting more of the story. I'm questioning, is this guy DV? Is he a good person? Maybe, is he just evil? Is he just built wrong? Those are questions you have to ask as a change agent, as a licensed professional. He choked his wife here. I mean, there's violence. There's a lot going on in this case study in a short period of time. As time goes on, his hatred and anger take over. The abusing mounts up. He's a con artist, a liar, a cheater, and a thief. Any good that was originally in him is gone. He discovers his mother is in an abusive relationship with some man, and he beats the man. He does short time in prison and gets out only to be more depressed about his life. He begins to feel suicidal, and that life has no purpose. So one of the things that I want you all to consider is the following. Is there a population? Is there a culture? Is there a religion? Is there a type of person that you will not work with? And there's no judgment in that, and there's no shame in that. Many times when I do supervision, I get, no, I'll work with everybody. And then we kind of chisel it down, and oftentimes what I hear is that people don't want to work with domestic violence perpetrators and pedophiles. Those are the two big ones. And then the third one, but not so much, is psychotic patients off their meds, of course. But ask yourself this question: is there a type of person that you will not work with? And then we can get into conversations about countertransference, because that is really what we're talking about here. Is why am I getting stuck with this person? What is it about this individual that I just can't get past? Is it the violent background? Is it that he hurt somebody? Is it that he's he lacks feelings? Is it that he lacks remorse? What is it? And then I wrote some things here to key things to consider. Does evil exist within families? Is it something that we can create a family tree about, and we can look back in time? Is there a lot of times violence within a family system is hereditary. Violence, it's generational. You see it growing up. What is the impact of mental health disorders? Clearly, this guy suffers from probably a few different types of mental illnesses. And what's the impact of that? And then just to throw this out, but where does medication, come in all of this? This one here, what is the true meaning of tough love? I want to say a couple things about that, because typically speaking, when we're dealing with substance abuse, we're dealing with drug addiction, we're going to be dealing with codependency and enabling and the concept of tough love. I'll be transparent again. I don't have the rule book on this, right? I have presented all kinds of scenarios to families, and I've presented what I say the DEFCON 5 example, the hurricane category 5, or the snowstorm, the worst snowstorm ever, or wherever you're from, earthquake, whatever. And families say all different kinds of things. Yes, I would let him in the house. No, I would kick him out forever. I would do this, but I'd only do it for 24 hours. Here's my message about tough love. Whatever you do, whatever they're going to do in this case study, you do it as a united front. Everybody has to be on the same page, which is really hard. It's really hard, especially, mom and dad are not on the same page, and they kind of have to negotiate and compromise. And again, that's why this is called a disease. Whether it's a mental illness or an addiction, it is very much like a grenade going off in a living room where everybody's sitting around and there's just shrapnel everywhere. The idea that mom and dad have to think about, what am I going to do with my child here? Do I walk away for a year? Do I, is it 3 months? Is it a day? And of course, what is the belief that mom and dad have? How is it impacting them? A lot of times dads who don't get as much press as moms, they really struggle with, I'm a failure as a man because my kid is a drug addict, or my kid is depressed. So now you're dealing with with all of that, and you have to be sensitive to it. But this idea of tough love and this sort of, this is the way it is, and I'm sure many of you have a way of thinking about it and have run into people that deal with this tough love concept. It's the united front piece that's important, not so much tough love. I will tell you this: most parents end up punishing themselves. Give you an example, a very simple example. They take Johnny's TV away from him for a whole month. And 3 days later, they give him the TV back, because a month away from a TV, the way the family is set up, is really a punishment for the parents, not the kid. And that is a lot of family therapy is about negotiating for change and what really works within the family system, not what works on paper, not what works in your head, but truly, honestly, what really works. Of course, personality disorders could be, that could be a whole aspect to this. And the children of the family are so critical. Most of my good work that I've done in family systems is because of the kids. The kids tend to be honest. They tend to be open. They tend to simplify things more so than us adults. And if we can get the kids to convey to the individual what's really happening, what's really needed, a lot of success, it rights the ship very quickly, and is a critical role to the success of a family for sure. We go to the next slide. Okay. This slide's a little bit shorter. 50-year-old man who has been a substance user, abuser, and addict can't consistently stay sober. well versed in the 12-step program and education high risk situations, denial of reality, finally gets treated for anxiety. While his anxiety has decreased, his cravings and need and want for substances, he wants them to go away. What happened? So key considerations are the stages of addiction, or really the stages of change. So I want to present something before I don't know where you guys are at in stages of change. You know, the pre-contemplation, contemplation, preparation, action, and maintenance. We can get to that in a minute. I want to introduce to all of you what's called circular questions. So the reason that I'm honing in on circular questions is that when you have a 50-year-old man who's got the disease of addiction, he's got anxiety, he's got all these things going on, we've got to hone in on both sides of the coin. And the way to do that is to ask a question a little bit differently 2 different times. And let me share with you how to do that. So let's talk about trust for a second, right? Because a 50-year-old man who's a drug user, I'm sure there's trust issues there. There's anxiety and trust issues and all of that. Was there a time in your life when you needed someone to trust and they were there for you? And then the second half of that is, was there a time in your life when someone needed you to be trustworthy and you weren't there for them? And then you go back and forth on the circular questions. And the reason that you do that is that you get to the conflict of what is actually happening with the person, with their anxiety, with their depression, with their addiction. So it's was there a time in your life when you needed somebody to trust and they were there for you? The other side of that is, was there a time in your life when you needed somebody to be trusting and they weren't there for you? And then you hone in on your own individual situation, which is, were you trustworthy with someone or were you not? And if you hone in on those areas, you're going to get specifics about whom that person was or those people are. And you're going to get into some of the family dynamics that he's probably not going to talk about if you ask him, hey, tell me about your family. It's a very powerful question. And Amanda, if the audience wants, I could write out those questions, circular questions. I could give like several examples of them so they have them as a tool if that would be helpful.
Yeah, absolutely. We can even have ask Elizabeth to put some in the chat as well, and we can send some out after the presentation.
Okay. And then of course, the family roles are critical. I talked about that. What is your role within your family setting? Many people think they're one role, but they're not. I'll give you an example, not to pick on men, but the man, he's the man of the house and all of that stuff. But I like to ask the question, not who's the man of the house, who makes the rules in the house? And then the other question I like to ask is, who's the disciplinarian in the house? Might be 2 different people and they might not be on the same page. The other powerful thing in a case study like this is how a person views themselves. One of the things I like to do is use a piece of Alfred Adler's, some of his therapeutic interventions, and he honed in on self, world, and others. How does an individual view themselves? How does an individual view the world? And how do they view others? And what I mean by that is, how do they see themselves, right? Are they a good person or a bad person? How do they see the world? Is the world a safe place? Is the world a big place? Is the world, chaotic? Is it violent? Is it peaceful? Are other people trustworthy? And I'll give you all a perfect example of how this comes into play in our day-to-day life. Many, probably all of you remember 9/11. On the 10th of September of that year, this entire world, and the United States specifically, was one way. On the 11th, we were another way. And that is a perfect example. That is a worldwide change in the way we view things. So just imagine in a family system, mom is healthy on December 7th, 2023. Mom has terminal cancer on December 8th, 2023. That family's world just changed. And so the view of how we see things and how it impacts our recovery and our anxiety and our depression is critical to our success, which leads me to this. I did very briefly mention the 5 stages of change, but more importantly, what I would like for everyone to hone in on is 3 things. 1 is optimism, 2 is commitment, and 3 is motivation. How optimistic are you that you're going to make these changes that you need to make? Right? Scale from 1 to 10. You start scaling, you start visualizing it. How committed are you to making these changes? And then how motivated are you to make these changes? And again, you will get the truth from them, even if they're going to say, I'm a 10 on all of them. Well, you'll know really quickly if they're a 10 based on their behavior. And that is critical to the success of a family, is honing in on what is realistic. So I spend a lot of time on building a family constitution with families. What really works within a family system? You know, how optimistic is this family that they're going to change? Are they focused on the right thing? Are they committed to each other? You know, how does it all work? Amanda, I'm good.
Okay. Thank you. Thank you so much for the case presentations.
You're welcome.
I want to open up this presentation to the audience and to see if anybody has any questions. Please throw them in the chat or the Q&A. I do see some that have come in that I'm going to begin asking. One of our participants asked if you, Ben, can share your thoughts on corporal punishment. Is that dropping from use, staying the same, getting more prevalent, etc.?
How am I seeing it in the world, you know, in the world, in the families that I'm treating?
Well, it sounds like it's more of a 2-part question. One, what are your thoughts on it, on corporal punishment? And then part B would be, you know, what are you seeing? Is it less frequent, staying the same, getting more prevalent, etc.?
So my position on it is we need to use our words and build our language skills, which are deteriorating on a daily basis. Just look at social media and texting and all that other stuff. So no, I'm not not in favor of it. And I am seeing an increase because of how I answered part 1. People are losing the ability to communicate with each other, and it's very, very troubling.
Yeah, I would even go a step, you know, when you spoke about, Ben, how, you know, there's a lot of different ways that we can define families, and family isn't always blood. And I think that even within people's sort of social families, there's been a rise in relational violence, etc.
No, absolutely.
Another question that came, it's question/comment, I would say. This individual is saying that they often find that the quote unquote well siblings are a critical part in the change in the family dynamics. Can you speak to that?
Yeah, I agree. A lot of times, it's almost like pulling the bunny out of the hat at the end. We've had we've had patients in treatment, and we're banging our heads against the wall. The parents are, and then we finally get in touch with the long lost sibling who has their act together, and it's almost like they were they're the truth of the family. They're sort of the barometer. They're typically the ones who moved away. They have their own life, they have their own kids, and they get to the bottom of things. Sibling relationships is huge. I spend a lot of times on building up siblings during treatment and even after treatment, even excluding the parents from that, because I feel like that generation, if they can get back together, the identified patient has a very, very good chance of recovering.
I would also say that it's important to really do some exploration when you're hearing about, just anecdotally, a well sibling, because they might be well on the surface,
Right.
because they have to be, because if they're not, then the family's homeostasis goes all out of balance. But
True.
under the surface, there's typically a good amount of pain, suffering, and they've experienced a trauma as well. And because they're not externally manifesting certain behaviors like the identified patient, their trauma goes sort of unidentified, untreated, and the pain is pretty deep in there.
Yeah.
Is there a tool to use to obtain self-image perspective for a client?
Is there a tool? I don't have a tool, but I do use the group a lot, in terms of building up self-image and how others see the individual, how the person sees themselves, and how the others see them. It really speaks to what I said about why am I afraid to tell you who I am. We do a lot of that within the group therapy and also within the family program. That there is a lot of that. Also, other families commenting on, not their family, but other families like that, kind of building that up as well, creates better self-image, or at least a more realistic self-image.
This is an important question. I'm just scrolling down a bit because we're getting a lot coming in. I want to bounce around. Do you have any suggestions on encouraging the parents of the identified patient to actively get support for themselves, either therapy, support groups, or Al-Anon, as they are trying to support their young adult child?
Yes, I mean it's critical that they get help. Oftentimes what I would do is separate them from the identified patient so they got their own therapy. You build rapport with them almost, completely separately. Find out what their willingness is, what they're really willing to do. Are they willing to go to Al-Anon meetings? Are they willing to go to therapy? Are they willing to come in for individual therapy or some family counseling? A lot of times families, they can't be together initially. It's not healthy. A lot of therapists rush to that, and they want everybody together, and let's talk about kumbaya, and let's make up, and let's do it. And that's just, it's not constructive. Like I said, the patient is the representative, not the problem. And sometimes the parents got to go on their own journey as well. So yeah, separating them and building them up as long as possible is critical.
Yeah, I totally agree with that. I think that so much so that we we tell families that, you know, we don't have that many like very rigid exclusionary criteria. But if a parent is unwilling to participate in their own coaching during the treatment process, then we're not the program for the family. Like it won't work. Obviously, there's some exceptions to that rule. If
Sure.
truly, like, it could be clinically harmful to have the parent like involved in a certain way, but it's really like very, very, very far exception. And
It is soul crushing to do all the work with the patient and not have the rest of the family, and a lot of times it's the parents, participate. And in fact, even further soul crushing when they show up at the 90th day or the 11th hour and make demands, which of course sets the patient right back to where they started. It's sickening, to see that in action.
yeah. How do you counter the belief of a client who identifies themselves only as the quote unquote black sheep in the family and cannot get beyond that belief?
I don't. Let them believe that they're the black sheep until further notice. They only have a limited amount of information. Many times a patient coming into treatment, you almost have to treat them like a child in that they have limited experience, whatever their experience is, and they've only had interaction with their own family system. So if they believe strongly that they're the black sheep, there's reasons for it. I'm not going to fight a belief, at least not yet. But I will build up my reserve, and eventually we'll get to the irrational beliefs of that person. But I wouldn't mess with that initially.
Yeah, I agree completely. I would be curious about it. I think that that's such
Yeah.
like wonderful. It's wonderful therapeutic content to really explore and understand, and you know, and there's probably validity to it.
Will tell you, Amanda, that I actually prefer when patients are headstrong in their beliefs. It's actually the resistance is easier for me. I don't power struggle with patients. I encourage them to believe what they want to believe, with the idea that if they hang in there long enough, we're going to poke some holes in their theories and their foundation, and they're gonna come to it on their own, at some point, because it's going to make sense to them that they need to make some changes, or their life is not gonna really amount to much.
Any thoughts on how to treat technology addiction, as it is unlike drugs, alcohol, and that you can get along in life without those, but you can get along in life without the alcohol or the drugs, but it's very hard to get along in life these days without technology to some extent.
It really is, an addiction. I mean, it's terrible. I mean, we're probably most of us on this Zoom right now are addicted to our phones or whatever. I mean, frankly, if you use the same principles that you use in 12 steps, you can be very successful. There's reasons why we're addicted to our phone, that we need it by us. There's anxiety reasons, there's depressive reasons, there's cultural reasons, all of that stuff. But I like to use the 12-step themes, when it comes to things like that. And even a step further, even some of the mental illnesses, that people suffer from, like OCD or what have you. I like to use some of the themes of the 12 steps to kind of break the cycle, for individuals.
Okay, I'm going to try to get to two more. One is coming from a provider who says that they often work with young adult clients who are coming from families where there's very high conflict divorce. How do you work with a teen in those environments, and how does that affect them later on in their young adulthood lives?
So really great question, and really difficult spot for that young person. That needs to be dealt with very carefully. That individual needs needs a safe place. The individual also needs a safety net within the family system, if there is one. Hopefully there's somebody, aunt, uncle, brother, sister, somebody somewhere that the person looks to. But the key for that is they have their own voice. They need their own person, separate and above from whatever is going on with the divorce conflict, the conflict within the divorce. They need to know that they matter, and they need to know that it's not their fault. That's critical for a young man or woman that's going through that.
Yeah. And there's also some we found that going back to an earlier question about the parents doing their own work, in situations where there is such conflict within a divorce or separation, sometimes the parents need to do coaching separately before they're able to come together in service of the family work. And that's okay too, but as best as we can, try to get them both to be running parallel alongside of each other, doing their own work, so that they can hopefully come together and co-parent. Because
yeah, I mean divorce is obviously it's a game changer within a family system, but the family's still a family, and they need wins. And what I mean by that is they need, sometimes they need to do things separately, but if they are together, a change agent like any of us, licensed professional, can put together something where the family can do something simple, where they feel like, okay, we got along for an hour, we did this activity or we did that, and it worked. It speaks to boundaries, of course, and lines in the sand, and and changing the approach of things. But a lot of times what you said is absolutely true. They got to be in separate rooms for a while until until the emotions cool down.
correct. And with that, it looks like we're going to have to close up. So I really wanted to thank everybody for being here and participating so actively in the chat, asking so many questions. Thank you so much, Ben, for your wonderful and important
Thank you.
presentation. This is our last presentation for this year. Please be on the lookout for email communications around the presentation schedule for next year, many of which will have CEs attached to them. And in the meantime, I hope that everybody enjoys the holiday season, the multiple different ways that we know people celebrate during this time of year. So we will see you in the new year. Take care.
Thank you very much, everyone. Appreciate your participation.